NTA language.
Jama'a masu kallon labaran NTA Hausa barkanmu da warhaka. Ni ne.
Ekukale lode yin wise kudede.
Igbo murum kachano.
Broadcasted in the language you understand better. Our programs. Transmitting on the Star Times platform 24 hours.
Àwọn onímọ̀ nípa ètò ẹ̀kọ́ lórílẹ̀‐èdè Nàìjíríà.
Hukumar tara kudaden haraji ta ƙasa.
Alani na ọchịchị mba United Arab Emirates UAE.
The only channel that speaks your language.
Anyị ga-eweta akụkọ gbasara ọrịa ahụ nke wakporo obodo anyị.
Kálejì, mo kọ́kùnrin, mo kọ́bìnrin, mo kí ọmọdé, mo sì kí àgbàlagbà.
Mu ci gaba da yi ma rundunar sojin ƙasar nan addu'a.
Ẹ kú lẹ́yìn tèmi, ẹ káàbọ̀ sórí ètò wa ètò yín ètò obìnrin tó dángájá.
Waye fi cancanta a ɗauka a matsayin ɗan aikin cikin gida.
Jama'a masu kallon tashar NTA Hausa barkamu da warhaka.
Kí ni ayẹyẹ ọdún iléyá tá máa ń ṣe lọ́dọọdún yìí rọ̀ mọ́?
NTA, you can't beat the rich.
The finals of the Men and Women African Cup of Nations. It's always frenetic. On days such as this, there are no tribes, no religion. Here, Nigerian warriors are out to represent, to show the skills that makes us the best. On days like this, the color is one. The color is green. When we get the job done, it is because we have stuck together.
It is mostly targeted at federal workers, and that the plan to enroll state and local government workers has not fully materialized, and it's far from meeting the yearnings of other Nigerians down the line. Now, how true are these allegations? How enlightened are subscribers in their rights under the scheme? How can more citizens benefit from the NHIS? And how can it be best positioned for effective results? Is there a thinking towards establishing community insurance scheme in Nigeria? Now, these are some of the questions we'll be examining tonight on NTA Tuesday Live. But first, let's get to see this report by Rabi Abdallah.
Available records show that every year 100 million people are pushed into poverty, while 150 million globally suffer financial hardship as a result of out-of-pocket spending on healthcare services. Universal health coverage aims to ensure that everyone, everywhere, can access quality health services without financial constraints in the process. This is because there is empirical evidence that the health of a nation significantly enhances its economic development and vice versa.
Everybody in the United States is covered by health insurance because they have to protect their masses. It's covering everything except body enhancements and libido.
In Nigeria, where out-of-pocket spending on health currently stands at about 70% and among the highest in the world, the National Health Insurance Scheme, established under Act 35 of 1999 by the then Olusegun Obasanjo administration, but only became operational in 2005, aimed at providing easy access to healthcare for all Nigerians at an affordable cost through various prepayment systems. The scheme had largely been restricted to workers in the formal public sector. For now, Federal civil servants make up the population of 3% of Nigerians covered, which translates to about 7.5 million out of Nigeria's population of over 170 million. Under the arrangement, the federal civil servant, his spouse, and 4 other dependents are covered. Professor Usman Yusuf is the new man at the helm of affairs at the NHIS.
Nigerians are made to contribute a certain percentage of their income into a health pool, not voluntarily, but as mandatory as they are asked to give pension. It will deepen and widen the pool of resources that can do a lot of good to many that get sick. But if it is voluntary, the pool is really very small. Essentially, for the last 11 years, NHIS has been the contributory scheme of federal government employees, not the state, not the local government. The 10% of their consolidated salary that used to be medical allowance was taken off and put in the pool. Every federal government employee should be registered, because the assumption is 10% of his consolidated salary has been put into this pool.
I have enjoyed the services. I have noticed is that there are some sicknesses NHIS does not cover. And I want the government to extend the services to those sicknesses so that we, the beneficiary, can benefit fully from the program.
Social health insurance in Nigeria is driven by key players comprising the NHIS, the health maintenance organizations, HMOs, the healthcare providers, and the enrollees. By its enabling act, the NHIS is saddled with policy formulation as well as regulate the activities of the HMOs. The HMOs, on their part, act as fund managers. They also collect contributions, pay capitations, and other medical bills for services rendered by healthcare providers. Findings show that the NHIS has not been able to actualize much of its mandate of universal health coverage in its 11 years of existence. This is in the face of allegations of corruption, impunity, and shabby treatment being meted at enrollees covered by the scheme.
Apart from the fact that it covered only a very significant percentage of Nigerians, it's also not offering enough in terms of the scope of coverage, in terms of the quality of what is acceptable, what is it allows. I mean, for instance, a situation where you allow only generic drugs. I'm an infectious disease person. I wouldn't want to treat any patient with a generic drug in a severe situation because generics are not very reliable. Authorization code. And then they expect you to announce the person's diagnosis on the phone.
Who requests for the authorization code?
The HMOs. I mean, you must tell them what the diagnosis is. In the first instance, it's one of the most confidential information of a patient you need to keep for this service to go on, for health care to remember what it is. It's the confidential about the patient's health, except the patient authorizes that. I advocate for a holistic review in terms of the scope, in terms of the coverage, in terms of what it constitutes.
But all hospitals in Nigeria depend largely on money from enrollees. You've taken their money, they come to hospitals, you treat them like lepers. It's not going to happen again under my watch. The national health insurance, the HMOs, the healthcare providers, that is the doctors, the healthcare facilities, which are the hospitals, are all complicit in why it has not worked. And I have many fora since I've been in this chair said what our faults are. And we need to take responsibility for that and say we're going to do better.
As health advocates recommend that the scheme be made compulsory, others have also harped on the need for NHIS to enhance its regulatory capacity to ensure compliance by all key players, while coming up with innovative way of generating the funds to pay premium for the health needs of the populace. The question is, how feasible and
of this discussion. However, as we always say, when you do get through at the appropriate time, especially on the phone, you would see your name appear on screen. That means the call has been passed through and it's taken. So we encourage you to go straight to the point, ask your question or make a comment, And don't bother too much about the greetings. Just go straight to the point so that more people can get on the platform and air their views. And whatever issues you raise, our guest tonight will be willing to address them. So welcome once again to NT Tuesday Live. Let's begin to look at the NHIS as a scheme and start off from the very premise of what the state of the NHIS is currently, and who are those who should be getting the best out of this system. Let's turn to the General Manager of the Formal Sector Department to kickstart this discussion.
Thank you, Cyril. The National Health Insurance Scheme has come a long way. We've been in existence now for quite a couple of years, and the Formal Sector Program, the flagship program, was launched in 2005. And since then, we've designed programs to cover every segment of the population in Nigeria. Today, we have a brand new chief executive. So we are in the process of repositioning and restructuring the scheme so as to achieve on our mandate. So that is where we are today. So the scheme is being reinvigorated, so that we'll look at our programs and processes and operations and see how we can do things differently to achieve universal health coverage.
Fine, good. So when you talk about repositioning, and well, it presupposes that certain factors have been identified as not going as smoothly as you'd rather have them go. So that's, of course, that's a basis for repositioning so as to provide better services. But we'll come to most of those issues. But let's go to Barrister Musa Hussaini. You were there at the inception and you were legal advisor to the scheme, and there were issues, questions were raised at that time about who was eligible to enroll in the scheme and the scope that we looked at. Tell us about that.
Thank you very much, Mr. Cyril. From the inception, we had a major challenge of determining whether or not this program is going to be a compulsory program, private healthcare services. So are they going to collapse that services under the NHIS now that is supposed to be a social program or not? So we had that problem at the initial stage. And you should also note that when we started way back about 11 years ago, there were no precedents. It was a nascent program. So, and every country has its own peculiar program on how to implement the program. The objective, the core functions and all these were quite a challenge, how to fashion the Nigerian consumer. Eventually, we thank God, the enabling law was promulgated by Abdul Salam regime, and it is being practiced now.
All right, that's a brief background on how we got here. So, right from inception, it was fraught with a number of challenges down the line. But let's come to the umbrella association of accredited, we use the word accredited health maintenance organizations, and there seems to be where most of the challenge lies. You are the president of the Health and Managed Care Association of Nigeria, the umbrella body. Surely you must have heard issues that have been raised about HMO's response to the scheme.
Thank you, Siri. Good evening, viewers. Actually, whenever we listen to problems or complaints, what strikes us is it shows the level of ignorance still within the enrollees. HMOs were created to be the eyes overlooking the scheme so that they are the operators. And that means any single problem that an enrollee gets, he should not quarrel or have any problem with his providers. All he needs to do is contact his HMO. You see that many of them don't even know they are HMOs. So we are to be your ombudsman. Any complaints, we make sure we get it right for you. And we are there to make sure that the quality health service that you need is granted for you. We know the tariff. we were there at the beginning when it was fashioned, and we have got contract with the healthcare providers. The enrollees will be treated by the providers. And any enrollee that believes is not getting the correct service, all he needs to do is call the HMO. It's part of the scheme. Because we are there to be the watchdog, we are there to be the ombudsman, the eyes overlooking those services to know that they are correct. And not only that, we are not just there for your curative. We are also there to make sure that wellness programs are entrenched so that your prevention and promotion of health are also constituted so that you can live a healthy life. So it's because they have not really known the importance of their HMO and got in to ask for it, for their rights.
Well, at some point we certainly would want to find out whose responsibility it is to give the widest imaginable enlightenment on the role of the HMOs and the providers, and just how much of that has been done in the past. Because if we still have this large, occurrence of ignorance, then it means somewhere along the line there's a disconnect between the enrollees and the body that supervises the implementation of the scheme itself.
All shareholders, we are all supposed to jointly come together and
do it. So we'll find out just how much has been done. But let's come to Dr. Isaac Abuja. We heard initially that there were some challenges at the inception because, yes, there was no precedence. And so you had to start something. But certainly, other countries were operating a national health insurance scheme, albeit in different names. So there would have been a kind of model which this scheme would have been fashioned after. Give us an insight into a number of countries. You've been around and seen this kind of scheme in certain countries. Give us an insight into how this is run in some parts of the world.
Yeah. There could be two basic ways of running this kind of scheme. There could be a centralized system like they have in the US. They have Medicare and Medicaid. And every employee is a subscriber to the insurance scheme, meaning that whether you like it or not, money is deducted from your salary for your health services when you need them. And in such circumstances, it is clear that you know you're right. It is clear that you have a fallback position when you are sick. And therefore, you know who to go to and when to go for health services. In other words, right from the beginning, like our colleague said, that it was supposed to be a social welfare scheme here. But now it has not been completely that way. In the United States, for example, Medicare is a social service scheme. Whether you are employed or not employed, as long as you are a citizen, you are entitled because you are subscribed for by the government, by the authorities that operate it. In a system where now it is a matter of privilege rather than a right, as from what we're hearing, the question is, what would you do to change things so that everybody will be entitled to treatment when they need that treatment, or health services when they need the service? And what I would say is, for example, that at every level, private or public, state, federal, or even local government, it is compulsory that everybody subscribes. And therefore, you have a good volume of money to play with, and there is a channel of communication between the provider, the health service provider, and the person who is running the scheme. What I see now from what we've heard so far that is a little different, and what happens in some countries, is that they have an intermediary, similar to what we have here, the health maintenance organization or the health management organizations. The difference I have seen here is that the healthcare providers are not also automatically HMOs in our own system here. We have the NHIS, you have the HMOs, and then you have the healthcare providers.
Right.
Therefore, there is a third party, an intermediary, between the person who is supposed to be the policymaker and supposed to take all the blames or all the credits for the people that subscribe to it, and the person that is receiving or providing the service. If things were done correctly from the beginning, the public awareness should have been created. People who are subscribing to the National Health Insurance Scheme should have been told how it would run, what their responsibilities are, what the responsibilities of the healthcare providers are, and those of the HMOs, separate from the NHIS itself.
Right. Let's now put them into segments. Right. We had said initially that it was expected that this scheme would permeate down to the local governments and even get to the private sector as well. It seems not to have happened. But let's even begin with the compulsory segment, federal staff.
Formal sector.
In the formal sector, and begin to see what the challenges are there. To start with, it would seem that, well, not much enlightenment, or there's a need for more enlightenment for enrollees to understand. But first and foremost, which are the ailments that are covered by this scheme? Because the first thing you hear from enrollees is that, look, I go to see my doctor under the scheme, and I'm told, well, you can't be covered under so and so. So let's get a broad, view of what is covered. What is it?
Thank you so much. Now, the benefits package of the scheme is quite comprehensive.
All right.
I must tell you this. It's quite comprehensive. I'll just list a few of them. It covers outpatient care, including the necessary consumables. It covers prescribed drugs and tests. It covers maternity care, antenatal, delivery, and postnatal services. It covers hospital care. It covers consultation with a wide range of specialists. So it's quite comprehensive. Yes, we do have some exclusions.
Right.
Services that are not covered. And I must tell you, in most climes, there is no social health insurance scheme that does not have exclusions. And why do we have such exclusions? It's because of the need to conserve the health insurance funds. I will categorize the exclusions into 3 groups. The first are services that other health agencies are rendering. For example, we don't provide antiretroviral drugs. We don't provide anti-tuberculosis drugs because other agencies of government are doing that. Now, there are some ailments that are as a result of our lifestyle or occupation we have chosen. For example, if you have injuries from high-risk sports, boxing, mountaineering, polo, we will not cover that. So you've got to pay for that. Now, for cosmetic surgeries, for example, you want to go and do mammoplasty, we will not cover that. So, and also very high cost procedures and investigations, like open heart surgery, like kidney transplants. These are high cost surgeries that can wipe off the health insurance fund.
Right. What about cancers?
Cancer is covered. Cancer is covered. So it's lack of awareness that make people believe that we don't cover so much.
Okay. Could we ask you at this point to just explain this, if you will? I'm glad you used the term wide coverage involving specialists. Now, this may also be as a result of not knowing. People who go up to the hospitals and say, more often than not, they get to the hospitals They're only made to see GPs, and not just senior GPs. I'll put it straight. We've got people who come around and say, look, you go in there, once it's under the NHIS, they push you to go and see a youth corps doctor. Anything that's beyond that, you pay. How have you heard that?
We have heard that.
Right.
And we want to get reports of healthcare facilities that are discriminating against our enrollees. We want reports. We want to investigate, and we want to sanction such healthcare facilities. You see, the way it is designed is such that there has to be a gatekeeper, and the general practitioner is the gatekeeper. Before now, what people do is, you have a headache, you want to see the consultant for something a general practitioner can handle. So the general practitioner is trained to manage a wide range of illnesses. And then if it is beyond him, or you require specialist care, he refers you to the next level of care, to a secondary healthcare facility or tertiary healthcare facility. So that is why when some people go to hospitals, those who are used to seeing their gynecologists at first visit, or their surgeons, they want to see the surgeon or the gynecologist, and they are told, please, you have to see a general practitioner first. So if you need referral, he will definitely refer you.
Under the terms of the, now this is coming to you, this is the legal angle we're looking at now, under those terms, what rights have the enrollee got in situations like this, where the enrollee believes that it's not been attended to properly?
Implied to his enrollment is a contract,
right,
between NHIS and all its agents, in quotes, which are the HMOs and healthcare providers. Interestingly, the Act establishing NHIS provides for a passage for the enrollee who is aggrieved, any enrollee that is aggrieved, to petition to a tribunal, and lay his complaint. The tribunal is supposed to be constituted by the NHIS, which is supposed to be a simple form of arbitration. You don't have to go to court. The tribunal is there for you. You can access it, made very simple, made very easy. But unfortunately, for whatever reason, 10 years after operation, NHIS is yet to establish these tribunals across the country to enable aggrieved enrollees to complain. And that is why, imagine someone from, say, Sokoto State who is aggrieved. How will he channel his complaint? The HMO maybe is in Lagos. The headquarters is in Lagos. Or the provider is maybe the special teaching hospital in Sokoto State. So he's just a poor enrollee. How will he challenge these people? So an outlet is made for them to petition in the most simple, basic manner, to the tribunal that is supposed to be established by the scheme to enforce his right under the program.
You superintend over the HMOs, and therefore it's possible that you would have, on your own, without even getting complaints from enrollees, seen a number of practices going on which are likely to put the entire scheme in jeopardy. Enrollees complain of not getting prompt attention, and the factor still remains that once it's the NHIS, well, then there's a soft pedaling, as I'm aware. But like the new chief executive of the NHIS said in the opening report here, obviously he's heard complaints like this, and he said not under his watch would this be allowed to, because the enrollees money is what sustains the scheme of the HMOs. What's your response to that?
Yeah, thank you for that. But before I go, let me just say one word about what he discussed. I'm using the medium to let enrollees know that this is a scheme. It's a system we want to put in place, a professional system, such that if you follow the system, things will be easy for you. We want an enrollee to go to the hospital. Don't bother whoever is put there, whether it's see the doctor. That will be the first contact, and that will be the gatekeeper. If you are not well, the scheme has been structured such that you can move from primary to secondary to tertiary. So you will be referred all along. So it is not to go to that place and have in your mind that you must see a consultant. No. Start with the gate person, the first primary care that you see. If you are not well, it is mandatory that you will be referred to a secondary. And if you are still not well, it is mandatory. It is still in the scheme. You will be referred to the tertiary. So we want them, the enrollees, to have that in mind. Then secondly, we also want enrollees to know that if you get to any hospital and you are not satisfied, don't quarrel with them. Simply call or text or send email. Now we are in the world of IT. There are millions of ways you can get to your HMO, and they are all there. Any HMO that does not have all HMOs have 24 hours call center. You can get them. You don't need to belabor yourself a lot unless you don't know your HMO. So their job should be first, and we always tell them, make your hospital to be either close to your house or close to your office, yes, so that it will be accessible.
That also has its own challenges, because I recall at the inception of this scheme, quite a number of people, enrollees, who were trying to go by this advice. Have your provider close to either your home or your office, and they had filled in those forms. You had a number of these organizations who returned them and said, no, we can't take more than XYZ. You have to go somewhere. In which case, they either allocate some place to you, or you go look for someone.
No,
that was
it is still the right. It is still the right of the enrollee to pick another place. It is still within his right. In fact, you have the right to change every 6 months. So it is, if that does not suit the enrollee, you can change again. So once you have chosen your place, then next, make sure you know your HMO. Because whatever problems you have, your complaints, your appeal, your grievances, it is the HMO that will solve it. It is when you have left that stage, then you can now think in terms of reporting to the NHIS, because it is the HMO that is the operator that it should do whatever you want in case you are not getting the actual services from the providers.
Yeah, as a follow-up, Cyril.
Yes.
You see, we have put mechanisms in place to address complaints from the enrollees. If an enrollee is dissatisfied with the services he's getting from a provider, he should call his HMO. And if that is not resolved, he should call the NHIS. Or better still, he can send an email to NHIS at sqa@nhis.gov.ng. If an enrollee has issues with facility encounter, if he has issues like denial of service, or with problems being referred to secondary care or tertiary care, he can send a simple email, and we will immediately deploy a team to that facility to address the issue. Or if an enrollee has issues with complaints on enrollment, he can send an email also to info@nhis.gov.ng. Now, when these issues cannot be resolved at the level of healthcare facility or HMO level, then there is this need to have an arbitration board, and this is in extreme cases. Fortunately, in all the years of existence of NHIS, we have not had any cases that we cannot resolve at the level of facilities or HMOs or NHIS.
Well, that might also be because the awareness isn't there for enrollees to take advantage of these channels. But we'll come back to that. The phone lines are already open, and we have a caller from Yola, Ayuba, who's calling in from Yola. Hello. Yes, go ahead.
Hello, sir.
Hello.
Hello?
Go ahead.
Hello?
Ayuba, your name is on screen, so go ahead.
Yeah, I can hear you. Yeah, hello? All right, I can hear you. Please, I'd like to welcome all the guests in the studio. All right, can you hear me? Yeah, Mike, I want to ask a question, please. Hello?
Go ahead.
Yeah, please, we are in the, hello?
I've got to say this again. We say it at the start of every program. Once your name appears, your call has been passed through. Just go ahead, ask your question or make your comment. And like we say, we encourage you to just go straight to the point. Just forget about all the greetings and just go ahead. Once your name appears, you're watching your screen, your name is there. We have said your call is through. Go ahead with your question or comment. That's the best way to go, and so that yes, we have from Lagos, Anthony calling in from Lagos. Hello, Anthony, go ahead. Yes, Anthony.
Yes, Anthony. Yeah, good evening.
Good evening.
I'm hearing you. Hello?
All right. We'll just cut off Anthony, and we'll ask you to call back later on. Yes, go ahead.
Yes, you see, part of the problem, the one that is in the open most of the time, is the problem enrollees encounter with the healthcare providers. But somehow hidden from the public is issue of access to HMO, and HMOs dictating to healthcare providers what services they should render, to an enrollee, almost dictating whether or not a procedure should be performed on a patient. So the HMOs are so powerful to the extent that you have an appendectomy, you want an operation. You have to have 2 levels of clearance. The healthcare provider agreeing that, okay, yes, you need this. But he will not do that procedure until he gets clearance from the HMO. And let's face it, HMO are private entities. They are profit-making organization. If that procedure is allowed, it is into...
Hello?
Hello.
Please, I want to ask the gentleman there. Any test has been good and we are all happy about it. But I want to ask them, anytime you go to the hospital and the doctor prescribes medicine for you, when you go to get the drug, you don't get any drug that the price of the drug is above 1,000 naira. They only give you vitamin C, folic acid, and the rest. Then I would like to ask the gentleman that said NHIS doesn't cover for big cases. But people have to pay for eyeglasses. That is a low price and the rest.
All right.
Please, I want to know why we all get what's cheap and we don't get what's expensive.
All right. Okay, Manchak, 2 questions, and I'm sure our guests have heard you, and straight away to address the first one. From the president of the, yes, of the...
Yeah, thank you. Let me state clearly for the providers and the enrollees to note. Any emergency, please go ahead and do it. You will be paid. That's number one. But if it is not an emergency, you are talking to us. We are doctors also, and we have many doctors in our employ. So we serve as a second opinion. That is why it is a must. It's part of the risk management structure in the scheme. It is not our doing. So that's why I don't want him to say it is because HMOs are powerful. No, HMOs must deploy what is called risk management strategies.
All right,
to find out what is happening.
Okay, but so, for instance, what Manchak...
No, I'm not talking about Manchak. I will talk about Manchak. Right, so I'm talking about his own, saying that we don't want to do that appendicectomies because they want to remove from our money. No, we want to be sure
considerations are not
appendicectomy. Okay. We want to be sure professionally that's why we want him to know, what have you done? Okay. What are the signs and symptoms you took? What is your diagnosis? Okay. We know.
Okay.
So when he talks or when he sends us anything,
calls from even the HMO, so then I got to know these names. And eventually when we had to go, the cost of transportation from Lokoja to the National Hospital was there. And when we got there from Lokoja, many costs we had to bear. Lokoja, at Abuja National Hospital, other issues came up. There were some drugs that were not on the list. Also, some equipment that had to be used, we had to purchase them, which was not even readily available. These are issues that
So now we have issues now from Matthew, and we're returning to those raised by Manchak. Yes, to deal with then given, as he said, vitamin C and everything that is below 1,000 naira.
1,000 naira. Still, we will still appeal to enrollees. You go to a hospital, you are not the doctor. First, listen to your doctor and see what the doctor has given you. If you are not satisfied, the scheme allows the doctor to refer you to the next stage, a secondary provider. And if you are still not satisfied, a tertiary provider. Because you cannot go to the doctor and ask that the doctor must give you so and so. So that is one. But secondly, I can assure you that HMOs are now working closely. In fact, we've started a special working together with the providers, so that we have had 2 good meetings and we have signed another contract to let them know that we are now monitoring.
You from Lokoja raised.
All right, thank you very much.
Good evening, gentlemen.
Evening.
I will want you, especially the barrister there, to address the legal issue that is involved in this matter. Because why I'm saying this is that the NHIS Act, what is happening to that program, some of the beneficiaries are supposed to take a legal action against it. Because it has come to the level of frustration that is going on. The beneficiaries are not getting what they bargained for. And I think that something is wrong. There is no information about our rights. Where we get where we take them for these rights are right. Something should be done that we should get something from these people, because we cannot be paying for services we are not getting. NHIS should be able to provide what they bargained for. The enrollees, when they go to the hospitals, they don't get what they want. They don't even attend to you in some cases. So please, we want to know, enlighten us on what we are going to do to get, if possible, some damages. By the time they pay these damages, I think all of what we are discussing will be a thing of the past. Thank you.
All right. Thank you, George. So let's quickly return to an issue that Matthew, the earlier caller from Lokoja, raised, which had to do with the extensive costs that they had to incur as a result of a referral from Lokoja to the National Hospital.
It's quite unfortunate that they had to bear such costs. He mentioned cost of transportation.
Such things occur all the time.
Cost of transportation and all whatnot. You see, when the hospital in Lokoja referred him to National Hospital, Abuja, naturally he will spend money coming to Abuja. But in terms of service provision, he should not have incurred any cost from the time he got to National Hospital Abuja, because we cover, or the package covers consultation. You don't pay. Drugs, you only pay 10% of the cost of dispensed drugs.
That's where those drugs are available.
You see, the medical doctor, the healthcare facility, has a responsibility to provide the drugs.
But you heard the man. In his own case, he said,
they need to document these things so that we can apply sanctions. We have sanctions in place. But the problem is, if enrollees do not complain officially to us, there's no way we'll get to know. They should complain to the HMO. They should complain to NHIS so that we apply sanctions.
In this case, he said it was extremely difficult to get the HMO, and it was frustrating. He used that term, frustrating.
One other thing they can do is to walk into the nearest NHIS office. We have offices in all the 36 states of the Federation. We have state offices. We also have zonal offices. So we have made provisions for them to complain so that we can address their complaints.
All right, we'll take a short break here. When we return in the next segment, we'll be asking to know the legal angle. Like the last caller, George talked about suing and claiming damages. Would also go back to Dr. Abuja to give us, another look if he's heard things like this in all those countries, in the schemes that they run, and give us an insight into how those countries managed issues like this under their scheme. So stay with us on NTA Tuesday Live. We'll be back shortly after this timeout.
Nigerians, our fearless officers and men of the Nigerian military are winning the war against Boko Haram. Today, all occupied territories have been recovered and Boko Haram has been degraded. Our affected brothers and sisters are getting their lives back. However, they are now after you and me. In our mosques, churches, schools, motor parks, markets, entertainment centers.
Essence as a nation. Let us renew the spirit of patriotism and hope in our dear country. Do not take or give bribe. Be punctual always. No more African time. We can't expect to be global citizens and operate on African time. Join the queue. Insist that people are attended to on a first-come basis no matter who they are or where they come from.
Nigeria, good people, great nation.
Make you report any crooked person, object or wakajugbe movement to police and security agent demo.
The security of our nation now work for all of us, plus including me and you.
Nigeria, make we unite against terrorism. Now, Federal Minister of Information and Culture bring on this message.
NTA Tuesday Live, a network issue-oriented innovation talk show.
Thanks for staying with us. And like we said at the end of the last segment, we're going to look at some of the issues that were raised. We'll also look at legal issues as well as see what has been done in other parts of the world. See these common complaints you hear all over the world. I'd like to think that perhaps they're not peculiar to the Nigerian situation. Dr. Abuja.
Yes, the most common thing that is done from different countries is that the person or the organization that is a HMO can also, and most of the time, is a healthcare provider. So he relates directly to, in this case, NHIS, meaning that the relationship between the two of them is understood, the type of drugs that are allowed are defined. Another person by phone. Supposing you are in an area where you cannot get across to the person, what happens? The patient dies?
All right.
And apart from that, I've also heard of complaints here where a healthcare provider provides the service, but the HMOs delay payment. And that discourages them from taking in another patient because they have already expended, they have not received payment for the patient they have treated, and then comes another patient, and they are crying to the HMO to pay. HMO delays 3 months, 4 months, sometimes ahead, more than that. And that doesn't help the system either. But if you were the HMO and the healthcare provider, all those will be eliminated.
All right. Okay, we'll just, so many issues have been coming, in text messages, we have them here, but let's quickly take Musa, who's calling in from Abuja. Hello, Musa.
Hello, good evening.
Yes, go ahead, Musa. Good evening.
First of all, let me say the insurance, the federal government has really tried. I say, first of all, let me start by saying
They tell you, sorry, we are not under health insurance for a particular service. It could be that that service is not accredited in that facility. Because, you see, before we take on healthcare facilities, we have to accredit them. Accreditation is a process of inspecting and assessing the services of that facility to ensure they meet required standards. So if a facility is not accredited, you will not be able to access care there under health insurance. So that is that. Matthew from Lokoja ended his comment by asking how can people in the state benefit from health insurance. And he also mentioned that he is a state government employee. Incidentally, states are free to fold into the program. Any state that has not keyed into the formal sector program, unfortunately, its workforce cannot access care.
How many states so far have keyed into this?
Yes,
and I think a way out is if Nigerians can contribute their own little quota on a daily basis into the funds for the National Health Insurance Scheme. I think all we've been saying borders around funds for the National Insurance Scheme. I'm sure if there's enough funds, every such ailment that are not yet covered by NHIS can be covered, even procedures. Recharge cards, phone recharge and even phone calls remain the constant business of the day in our country today. And even if as minute as 0.5 to 1% of the recharge card that value is sent into the National Health Insurance Scheme, by so doing, every Nigerian will contribute into the revolving fund of the NHIS, and by that, every Nigerian would also be an enrollee. And again, I think the NHIS should make their system more computerized than it is right now, so that the idea, the delay in getting clarification in the hospital when you present as an NHIS enrollee is shortened, because that can determine a patient's outcome depending on the ailment. But also decentralizing the NHIS is very important. That NHIS is broken down to community health insurance schemes, as one of the audience, one of the personnel on TV said. It should be broken down to community insurance so that those at the grassroots level can afford to have a close contact with NHIS, because a lot of people don't even know what the NHIS stands for. A lot of people don't even know if there is anything called NHIS. But if as much as we have primary health care centers in our rural environment, NHIS can also be taken to that level, then people will have contact with the NHIS. I think these are some important things that should be brought into the NHIS for the NHIS to function appropriately. It's a very important scheme. It's working in advanced world. It should work in our country. All we need to do is for us individually to contribute. And I say the NHIS can make millions of naira per second, per minute in their account if they can actually relate with the National Communication Commission to ensure that every Nigeria contributes its own little quota into the NHIS on a daily basis. Thank you very much.
Right, thank you very much. Okay. All right, and still some other issues outstanding here. Yes, Musa also raised the issue of you touched on it. You said it's possible that certain services may not have been accredited in a facility. He made specific reference to dental care.
Yeah, dental care is covered. However, in a particular facility, maybe the one he went to, dental care may not have been, dental services may not have been accredited. So these are issues we need to really understand.
Well, messages have been coming through, and let's take some of those messages, and before we go on to the legal angle again. This one is from Mariam Isa. Said Nigeria is set to spend only 1.1% of its GDP on healthcare services. With this, how healthcare under the NHIS scheme can be improved? This is Mariam Isa who's asking that. And we also have M. Hassan, who says, in its mission statement, the NHIS states that every Nigerian is entitled to health care. Yet, only about 5 million out of an estimated 170 million receive adequate care. Who is to blame? Is it the lack of what he calls bureaucratic coordination, or is it poor funding?
Yeah. NHIS is set up to provide health insurance to every Nigerian. But we have developed programs to cover every segment of the population. Social health insurance is a contributory program everywhere in the world. So somebody has to make a contribution into the common pool. For those in formal sector employment, they are making contributions. Their employers are making contributions at the federal level. But the states now need to do the same to cover their workforce. But unfortunately, not too many states have shown interest. However, there are some states who have made some progress in establishing their health insurance agency for the purpose of keying into health insurance in the country. About 6 states have passed their bills, and about 2 or 3 states are having their bills debated at their state assemblies. So it is our hope that these states will pass their bills and establish their health insurance agencies so that their workforce and the rest of their citizens will start benefiting from health insurance.
Okay.
And if this happens, then we will be talking about an increase in the percentage coverage of Nigerians. Also, there's the vulnerable groups in this country. Those who, as a result of not being economically able to earn some income, cannot make any contribution. And somebody has to pay for them. It gladdens our hearts to know that the National Health Act, Section 11, makes provision for the creation of a basic minimum healthcare package fund, provision fund. Now, this healthcare services provision fund is going to be financed from a grant from the federal government, not less than 1% of the consolidated revenue fund. So NHIS is going to get 50% of this, and we're going to use it to provide basic minimum healthcare services to every Nigerian, those who cannot contribute.
All right, so let's go to the pending legal issues that were raised earlier on.
Yes, a caller did raise the issue of his legal rights and remedies. You see, the program is designed in such a way that the right of choice is really with the enrollee. He can decide so many things. One, he can delist NHIS, and if you are not satisfied, and if by the conduct of healthcare provider you suffer some injuries, you have a right to sue the provider for professional negligence, because all the professionals in that facility plus the facilities are expected to be covered by a malpractice insurance.
Okay.
So people should be encouraged to do so.
Let's go over to Port Harcourt. We have Tammy on the line from Port Harcourt. Hello, Tammy. Okay. Okay, we lost that call right there.
We are still our brother's keeper. Some people will go with him to the hospital. Like he said, when Mansha phoned the other time, he went with some people to National Hospital. Any of them could have phoned or sent an email. There are many ways now of reaching. Or there is a call center that you can get 24/7. But that the HMO has.
Right. Calling in from Calabar, we have Ahiru from Calabar. Hello.
Good evening, sir.
Yes, good evening.
Good evening.
Good evening. Go ahead.
Hello? Good evening.
Basically, we are covering the federal civil servants and their dependents who are in Adamawa State. Then we have community-based health insurance programs, running in 1 or 2 communities. Incidentally, Ahiru did not tell us what program he was referring to.
All right. Isaac from Gombe is on the line. Hello, Isaac. Go ahead.
Yes, my question is to the HMO man in charge.
Okay.
Why do they delay payments of fees?
Right.
Why do they delay payments? What is the problem?
Thank
and
you.
then two, what qualifies a hospital as a secondary service provider? And how does one go about that?
Okay. Right. Thank you. Straightforward.
The scheme does not allow anybody to delay payments. In fact, within ourselves, we make sure that we let people know that payment, especially capitation payment, should be as fast as possible. And the NHIS are here. They can tell you that there are some HMOs that don't delay payment at all. So if there are those who are still delaying payment, please report them. Name and shame them. We have told them several times. Please, anybody that is delaying payment or is not making payment, please report. Name and shame them. We don't support any HMO that is not paying. You can be a primary health center or a small clinic to be the primary care. But to be a secondary care, you must.
HMOs we have right now, in my opinion, are insurance brokers. They are not HMOs. How do you manage what you are not offering? I gave an example of the US. A HMO is a healthcare provider. So you know exactly what your responsibilities are and your liabilities are too. But here, you have somebody who is supposed to be representing you to monitor the healthcare provider, but he is interested in making profit. And it is at the cost of making profit that the trouble arises. I heard of a case where the provider sends a bill, and the HMO says, no, this bill is too much. We cannot pay you this, and they slice it. And the guy says, but this is what I spent to provide the service for the patient. And they say, no, okay, we'll pay this. That should not happen. There shouldn't be a negotiation as to how much you should pay. There has to be, for this disease or for this treatment, this is the charge. For this test, this is the charge. And it is standard. If that is the case, and NHIS has that, and the healthcare provider has it, then there's no argument.
For negotiation.
You provide the service, you get paid. And where we still have problem is this issue of expecting somebody to be a clearing house for HNIS. If I have my way to suggest, and I do suggest, that instead of having to go through HMOs because of the problems we have here now, it would be better to have healthcare providers relating directly to NHIS.
Okay. Port Harcourt, we have Willie on the line. Hello. Willie's gone? Okay, fine. We got, just before you come in, we got this message. This is Farida Salman from Maitama. And Farida says, I'm aware at inception NHIS had only 8 HMOs. Okay. Those were the only ones accredited, and the quality of service was quite good then. And then she asked the question, how on earth did the number over time swell to almost 60? Thereby giving credence to the saying that many cooks spoil the broth. What is NHIS doing as a regulator to put a check on the proliferation of HMOs, as some of them really don't have what it takes?
Currently, we have 59 HMOs.
59, 60, well,
yes,
that margin of error is...
and I will tell you, one is currently on suspension because of malpractices. So we have started the process of really pruning down the number. Because, like I said when we started this program, we are repositioning, we are restructuring, we have a new chief executive who is committed to ensuring that due process is followed in everything, that we have quality service delivery. And no HMO who is engaged in sharp practices is going to be spared. No healthcare facility that is engaged in sharp practices is going to be spared. So over time, these HMOs are going to be reaccredited, and those who do not meet the reaccreditation requirements, which will include performance records, definitely they're going to be delisted. So this is the time for them to sit up, because we've had a lot of issues, complaints, even from calls we are getting here about the performance of HMOs, the quality of service they deliver. So these things are not going to be passed under the carpet.
All right. Gambo from Nasarawa is calling in. Hello, Gambo.
Yes. Hello, good evening. All
Yes.
the gentlemen in the studio.
Evening.
Hello.
Hello, go ahead.
My name is Gambo Matazu from Nasarawa. Let me continue. I couldn't have you in my phone, but I thought you are hearing. Well, actually, I'm very happy with this program and NHRS because there's one of my late brother. He used to go to the hospital and receive treatment, him and 5 of his children. Actually, the program is very nice, and I hope the federal government will extend this program with the old men, like 70 years or 60 years above, and the children under 5 years. I think the program is very nice, and I think I hope the federal government will extend this program to another level. And one thing is that there are some of the beneficiaries who used to go to the hospital and receive medicine. Instead of them to use it, they used to sell it out to pharmacy. So I think that they used to, the federal government, they need to think out of us how to reorganize all these kinds and the sabotage of the program. Thank you very much. Have a wonderful day ahead. Thank you.
Right, thank you. Okay, well, that's one individual whose views must gladden the hearts of the NHIS here. But let's go back to, well, incidentally, the call came from Nasarawa. So all right.
Well, I want to lend more credence to the issue of delay payment, which my colleague here says there's nothing like this. But I know that we have a big problem with delay payment.
Yes.
By the regulation, HMOs are paid even in advance. So there should ordinarily be no reason whatsoever for them to delay payment to healthcare providers. But we do experience them. You go to the hospital, the provider will simply tell you that, look, I'm not going to attend to NHIS patients because there's irregular payment. When we started, NHIS enrollees were darlings of facilities. They created special wards, special waiting areas for NHIS enrollees. But these days, you are treated with scorn. You know, and this is because a failure on the part of NHIS to do its duty. They don't adequately supervise the activities of HMOs. HMOs have become like a stronger body than the NHIS. I'll give an example. The law requires that money that is given to HMO, they should make continuous periodic returns. How far has that been discharged? You should understand there are two payments to HMO from the general money that is collected. The money is pooled. You say you have about 10% or 100% of money collected. Then there's a template on the portion that each of the principal stakeholders in the program are supposed to get. For services, about 70% is a mark for services. That is both fee for service and capitation and fee for service. I'll explain this. Then you have 10% dedicated to HMO as admin cost, administration cost. Right? Then you now have this 70% is given to HMO to manage the care and pay those 2 tiers. Right? Then 10% is given to NHIS on a product of 5% of that 50% of 10% as admin cost. Then 10%, 5% is dedicated to what is called reserved fund in case of problems in the implementation of the program. And then to also embark on a robust. That is why it will be beneficial to them if they deny you access to health care.
So all that money remains in the kitty.
Yeah.
You didn't quite agree with that.
So you're getting this money from...
Okay, so let's understand.
Okay.
The capitation should be paid every penny to the provider.
Right.
The NHIS is here. Please, from today, any HMO that does not pay that capitation should be immediately remove its license. That capitation, because the risk of the capitation is borne by the providers. 100%.
Let's go to the template of monitoring when this returns. You have that in practice?
Yes. We monitor the returns. But we monitor the returns. However, the issue has been enforcement of the provisions of our guidelines. And like I said, we have now elevated the enforcement unit or division of the scheme into a full-fledged enforcement department. So NHIS is going to bite more now. NHIS, we have passed the stage of backing. We are now going to bite. The new executive secretary has said it in every event, every fora, that look, we are going to enforce.
So if we are having these challenges in the formal sector and formal public sector, you think it's wise to go into the private sector? Keep the private sector keen?
We started the private before the NHIS was launched in 2005.
And
we started the private, HMO started private health insurance, and we've been doing well. All multinational corporations are on. It's just that we now want to get to the informal sector, government to come in and make legislation compulsory to enter the market so that the penetration will be rapid and fast.
And that is the beginning. That is the beginning of the problem that NHIS is made to bear. Because, like I said, there are two types of insurance, health insurance: the private and social. NHIS is supposed to be a social service. Issue of profit is not there. But some of our colleagues have started the private sector health insurance for, private health insurance for a very long time. So, yes, before the enrollment of NHIS. Now, when you register them, you have given them the opportunity to carry two services, two different services at the same time, from under one roof. There's bound to be conflict of interest.
Dr. Abuja.
Yes. I would suggest that it is done in stages. The first stage now from NHIS is to go to the states and get the states to be part of the system. Because insurance it operates on the principle of economics of scale. In other words, the more the number of people enrolled or that are subscribing, the cheaper, the more efficient, and the more effective the system works. The money that is pooled together is more, and therefore the healthcare provider is happier, and the beneficiary, the subscriber, is also happier. And when you do that, some of these conditions that you even say now are not included or are not covered will be covered because you would have enough money to do that. And then if you have to do that, I would again insist, the 10% that you are paying to HMOs now can come back to the pool. Plus, the fee for service, which I understand is about 112 naira per enrollee. That's a lot of money. That's aside from the capitation, which is 750 naira.
Yes, the HMO does not collect
wait,
capitation.
let me come. Ideally,
Providers' money.
The fee for service, which is 112 per an enrollee, is supposed to be returned if not used, if I understand it correctly. The problem I hear is that the HMOs are not even returning the money. That's aside from the 10% that they are keeping as their administrative fee. And the only thing that we are sure that they are paying directly to the providers is the 750 naira capitation. That's the only one that is guaranteed. So they're making profit from the right and from the left. If NHIS wants to go and enroll the private sector, let them move the next step first to the states and then the local governments.
And while all this goes on, the
Patients are
enrollee is the worst for it.
You see, that is quite true. We have said it over and over again that in any conflict between the enrollee and the healthcare facility, the enrollee is the underdog, and we will be on the side of the enrollee. And when there's an issue between an HMO and a facility, or between the HMO and an enrollee, we will be on the side of the underdog, the enrollee. It is because of the enrollee that we are all in business.
Exactly.
Therefore, the enrollee is king, and he must get quality service from every other stakeholder. You see, there's one other thing we are doing at NHIS.
Right.
We are developing our ICT infrastructure so that we automate our processes and operations end to end, so that we can interface with all the stakeholders real time, the HMOs, the healthcare facilities, so that any issue of service denial, any issues of poor quality service delivery we can address it real time.
So,
let me just
okay, right.
Because it's good. I have in my HMO, a student of University of Lagos. All he paid for a year is 4,000. He had a road traffic accident. He's been on admission for 2 years. We are still paying. We paid more than 2 million for somebody who paid 4,000 in a year from fee for service. So to come and tell us that whatever, and from August, I've noted that all the bills I've been paying are higher than whatever NHIS is paying me per month. That is what they call insurance. The fee for service we are talking of, we pay out sometimes every month more than what is paid to us.
All right.
That is the risk.
Okay. As we wind down, there's an important issue which Fatima Isa has sent in here. And it says, the current practice is such that an enrollee retires from service and ceases to enjoy health insurance coverage. And this is the period they need it most in view of the numerous health challenges associated with old age and aging. Can anyone explain why this is so?
In one of the comments, I said social health insurance is contributory. Your employer makes a contribution, the employee makes a contribution. Yes, we do realize the fact that when you retire, you become an old citizen and you become more vulnerable. That's why I said NHIS is delighted that 50% of the 1% coming from the national, from the Consolidated Revenue Fund is going to be used by NHIS to provide healthcare services to those who cannot contribute. And I mentioned the vulnerable groups.
Right.
Children under 5, the aged, those with disabilities, the very poor people, those who are too poor to contribute.
I like that, going to. So when is this?
Well, when is this? That's a tall question. Well, as soon as the money is made available. But meanwhile, we have a retirees program. But like I said, somebody has to fund the program. We have commenced discussions some time ago with the PENCOM to see how we can collaborate with them so that retirees can transit from the formal sector social health insurance program where they were enjoying services and then to this retirees program. So we're still working on that. But whichever materializes first, we are assuring our senior citizens that very soon, in the not distant future, they will begin to enjoy health insurance coverage.
Well, and I dare say on behalf of those senior citizens, we're actually looking forward to that. Well, we've just about run out of time on this program. And yes, you'll recall we say it all the time, no one program can take care of all the issues. And so at some point we'll have to leave it and hope that in the very near future, we will come back to the issue of the NHIS. And borrowing the words of Dr. Walker here, as you say, there's a new sheriff in town. We're going to want to see how this sheriff is keeping law and order in the NHIS. So we'll ask you to come again soon to see how you have repositioned to make the scheme more effective and efficient. At this point, we'd like to say thank you very much to Dr. Emmanuel Uhuakanwa, General Manager, Formal Sector Department of the NHIS. Thank you for being here tonight.
Thank you so much.
And it's nice to have you again, Barrister Musa Hussaini, who was the pioneer legal advisor to the NHIS and as a one-time Attorney General of Nasarawa State.
Thank you for having me.
Yeah, I do know a lot of enrollees would consult with you at this point because they would want to enforce their rights.
Yeah.
Perhaps when that happens, being the intermediary would get the commission.
Okay, no, we'll do it on pro bono basis.
Okay. Well, for Dr. Kola Owoka, who is the President, Health and Managed Care Association of Nigeria, that's the umbrella body of accredited health maintenance organizations. We like to thank you for being here, and we look forward to hosting you again to find out just how well you have dealt with the issue of the HMOs that we discussed here.
Thank you for having me.
And for Dr. Isaac Abuja, as a public health specialist, we thank you for sharing your thoughts with us here. Thank you once again.
Thank you very much.
And to all of you who stayed up with us till this point, we say thank you for being a part of NTA Tuesday Live. Next week we'll reach you again. My name is Cyril Stover. Bye for now.